You're listening to Aging Uncensored.
Okay, hello and welcome to Aging Uncensored, the podcast where we fearlessly delve into the unfiltered realities of growing older and navigating the world of caregiving for our beloved seniors. I'm your host, Christy Baines, and my co-host is here with me, Nicole Crawford. And we have a very special guest today, Dr. David Geldmacher from the University of Alabama at Birmingham. And we will dive into all things Alzheimer's, dementia, and interesting things going on in the world of neurology. We are so excited to have you on here. So grab a cup of coffee, get ready to go. I know I definitely need lots of coffee today. And we are so excited to get this started. And we will have Dr. Geldmacher with us for a two-part series. We really could probably make him a four-part series because once we get into this, y'all are going to realize what a jewel and just a huge opportunity we have in Alabama and in the Southeast and really across the world to have his knowledge, expertise, and his team's knowledge and expertise. So Dr. Geldmacher has been a physician for many years. He's been in the Alzheimer's and dementia area since 1991. So clearly you have seen decades now of how this has grown. I know Nicole and I got into this world in the late 90s as well. And so watching the therapies, the research, all the things that you and your team have brought to the world for patients living with dementia and their family caregivers has really changed a lot of the ways that probably you practice and the way that you meet with patients, and also the way that we deliver our services and care. So Dr. Geldmacher graduated magna cum laude from the University of Rochester in New York with a BA in biology and psychology. He obtained his MD with a certificate in academic research from the State University of New York Health Science Center at Syracuse. And he undertook his training in neurology at Case Western Reserve University and completed a postdoctoral fellowship in behavioral neurology at the University of Florida. He has received many awards, including the Best Doctors in America and Who's Who in the World. And we are actually going to ask you about things that are going on in the world in Alzheimer's. But probably the first one is, and I thought this was a very pivotal shift for your entire clinic, is when you joined UAB and you were brought here to bring the expertise and dementia research that you have. And that was probably about 12 years ago?
Yeah, 2011 is when I joined UAB.
Yeah, 13 years ago. So it was the Division of Memory Disorders and Behavioral Neurology. Now, y'all are the Brain, Aging, and Memory Clinic. Why the shift?
Sure. So there's a couple of elements to this. The name of the division of Memory Disorders and Behavioral Neurology and the name of the clinic at the time, the Memory Disorders Clinic, reflected the state of the art 20 years ago, which was we cared for people who had changes in cognition, typically memory, but not only memory, and studied those individuals in our research programs. As we have moved forward, as the dog barks in the background, we have moved to understanding more about the way our brain ages and the way our thinking changes with that, memory and other parts as well. And we felt it was important to shift our emphasis to brain aging and its consequence of memory, and not just the disorder of memory. The other reason that that's important is our therapeutics, our treatments are moving earlier and earlier. And so not everyone who we will be treating for neurologic disorders that affect memory will have memory problems when we begin those treatments. Right now, we still do. But I think within 5 or 10 years, it's very likely we'll be treating memory loss and Alzheimer type change in the brain in a more preventative manner rather than responding to the symptom of memory loss or memory disorder. So that's what underlay the change in our our nomenclature. So now we're the Brain Aging and Memory Clinic and the Division of Cognitive and Behavioral Neurology, reflecting what we do and who we care for.
That's so exciting. I mean, for the first time, Nicole, we're hearing the word preventive, right?
I love
Preventive versus being, responsive, reflective, responsive, whatever the word I'm trying to come up with today. Y'all know what I'm saying. That's so exciting. Thank you for that. I think when did you make that shift? Was that in the last year or so?
Yeah, it's within the last year or so. At the same time as we were planning our move in space, so previously our practice had been located in the Kirkland Clinic at UAB, in collaboration with the hospital, we were moved to new space in the Callahan Eye Hospital, and our name changes more or less matched with that move in geography.
That's wonderful. And tell us about the new space. I had a opportunity to tour it with you, and it's extremely impressive. You've got a lot of unique things that are specific for folks, the person living with dementia, but even more importantly, the family.
Yeah, so we've grown a lot over the last dozen years or so that I've been fortunate enough to lead our program, and we've actually grown to the point where we had 3 different physical locations for our work. We saw our patients in the Kirkland Clinic. We had our offices and our research program in the Sparks building 3 blocks away. And as we added more case managers and more nurses and social workers to our team, we actually were in a 3rd space on the other side of Kirkland Clinic. So the move to Callahan allowed us to integrate our research operations, our offices, and our clinical operations all in one space. So it's about 20,000 square feet, all brand new remodeling, and allows us to integrate those things. We have some updates and upgrades that we've been able to put in place as well. So not only is everyone on the same floor, but in the waiting room, they now have message boards that remind people about brain health or reflect on members of the staff and their achievements and who the patient and their family will be seeing. And one of the things I'm happiest about is we've been able to create a gallery space on the 5th floor for an artist in residence program. And we now have our first display for an artist in residence. And it's a photographer who, Manjari Sharma, who documented her mother's course through dementia and her family's care of her mother. And so we're able to use that art to help tell the stories and help families resonate, understand that they're not alone and that others have done this and have thrived in the process. So those are all exciting parts of our new space for us.
That's great. Tell me about, what does the team look like? How many, you mentioned case managers. We obviously know you've got advanced practice providers. You've got a number of different MDs. What does that look like?
Sure. So right now, there are 5 physicians who practice in the memory disorders clinic, or formerly memory disorders, now Brain Aging and Memory Clinic. We're all academics. We all have other roles beside patient care. So between the 5 of us, we are seeing patients about 9 half days per week. And we have various backgrounds and training. So 3 of us specialize in the cognitive and behavioral aspects. Another has training in movement disorders, and so is able to help work with the people, say, with Parkinson's and related conditions. And our 5th is a person with a background not only in neurology, but also palliative care. So we have this expertise across our physician team. We have 6 nurse practitioners who work in our group. 4 of them are full-time with us, and 2 spend about a half day a week and have various expertise as we put together our nurse practitioner team. I wanted to include people with different backgrounds. So we have folks with home health and hospice, or inpatient psychiatry, or research and behavior management, all working on our team together. Right now we have 3 nurse case managers, RNs with a specialty in case management. We're about to add a 4th. They help us manage the patient load by getting background information for patients and families before visits. They help to manage the very complex aspects of modern treatment of Alzheimer's disease with some of the new medications. We've got a couple of social workers. We've got registered nurses who help manage the patient population and also greet and bring our patients back to the room. So it's a true multidisciplinary interprofessional team that we have to help take care of the folks.
Absolutely. So when a patient or a family is, embarking on this journey, what they getting from you guys is an entire family of folks with all different unique experiences and abilities that is bringing this team approach to the patients. It's not just, I'm Dr. Geldmacher's patient, I'm the brain aging and memory team patient. And so therefore, sometimes you probably, even depending on what's going on with that patient, you may shift as to who the nurse practitioner might be seeing them that day, or the social worker, based on what you're experiencing or what the family is sharing their experiences with you when they're entering the clinic.
Very much so. Our physicians' expertise is in recognition and diagnosis of specific illnesses. But we know from the literature, from the science that's been done across multiple disciplines, that a majority of the needs of a family facing dementia lie outside the domain of medical practice. And so the nursing is the core of our practice, really. And 90% of the needs identified by patients and families fall into the domains where nursing provides the greatest expertise. So that's why when someone joins us in clinic, they're going to be seen typically by a physician and a nurse practitioner for most new patient visits. And then that nurse practitioner will take over ongoing management of the person throughout the course of the illness, always with ready access to the physicians. We're on the same floor. But those kinds of ongoing clinical decision-making processes and support for the family in doing it is led by a nurse, and for good reason.
Right. And yeah, no offense, Dr. Geldmacher, y'all are amazing. The physicians are great, but your NPs really are the heart of what your clinic provides. And that is an education, and Nicole, pitch in at any time, that is truly the education that we provide families that, when we get the question all the time, and this is one of the ones we kind of send out to you. Clients will say, but I want to see a real doctor, right? Well, they probably know a little bit more than you do sometimes in these situations, right?
So our nurse practitioners have a lot of expertise and a lot of experience in the care of the person with dementia. We've had people with us for 7 and 8 years, and others have come to us from the world of geriatric medicine. And so a lot of expertise in these hands-on management. And I don't want to emphasize just our nurse practitioners, so that if someone calls our clinic, they're going to be speaking with a nurse, a registered nurse, who can do a lot of that management of nursing needs and the like over the telephone or through the patient portal. So yes, we're very much not a physician-centered practice, but rather an advanced practice nursing-centered practice with support from other disciplines, registered nurses, case managers, social workers, and so forth. And that's where the true expertise lies in our group. It's relatively easy to find a doctor. It's relatively difficult to find a dementia expert, and our nurse practitioners, our registered nurses, are dementia experts. Yeah.
Thank you. It's amazing to see how it's changed over the last 13 years and where the practice has grown and how many folks y'all are helping. So I think you were giving me some of the numbers. Y'all have got a pretty large patient base that you're seeing on a regular basis. What's kind of how many annual visits do you think your clinic, or how many annual touches as a whole do you think you guys are providing?
So touches, if we include things like phone calls and portal messages, I don't have a number for that. But in terms of billed visits, that is interactions with a provider that results in a charge, we're at about 4,500 per year now. That's up from about 1,500 when I started. And in terms of the people, how many individual patients, we have about 2,500 individuals in care at this time. So obviously some people come in more than once per year, but that's a pretty large cohort.
Yeah, absolutely. Walk us through, so we're going to kind of keep on with the clinic and the patient experience right now, and then on the second half we really want to dive into the more exciting things that are like the research, what's coming down the pipeline, all the things that you've been embarking on across the world, literally across the world in this past year or so. But walk us through, a patient comes to you, right? And so we might even dive into, let's say this is definitely someone that's going to be more in the mild cognitive impairment area, right? So they're kind of newer in maybe their disease process. Probably maybe the family had a little bit more of an awareness of what's going on, and so they were able to get connected with you guys before this was kind of later in their journey. What does that look like?
So a typical pattern for this is either the patient and family or their primary doctor identifies a need for brain aging and memory clinic. And that could be hearing about us through programs like this, or searching the web, or we have a strong referral network of primary care providers will send folks to us. So the first contact after an appointment is made is typically with one of our nurse case managers who will reach out and get a summary of the history of what's been happening, what the family's needs are, what their resources are. Sometimes that case manager will identify more acute needs, something that we need to prioritize, put that person at the top of the list, particularly for things like social work services or medications to control difficult behaviors and so forth. That's less common in mild cognitive impairment, but it does happen. And then at the initial visit, most often the visit will start with one of our nurse practitioners getting more detailed history and memory and thinking testing. We are a teaching hospital, a teaching service, so along with that nurse practitioner, there might be a resident in neurology or a medical student who's participating in that portion of the care. They review that information with the attending neurologist of that day, so it might be me or one of my colleagues, and then we go in and review what we know, order the tests that we need, and move on to the next step. And those tests might be blood tests, MRI scans, PET scans. There might also be referrals that are involved. Do we need more detailed memory testing with a neuropsychologist? Do we hear things that make us think that interrupted sleep might be contributing to the memory and thinking problems? And so those people we might refer on to our a sleep specialist for detailed evaluation of that. I think it's important to note that in mild cognitive impairment in particular, there are a lot of non-neurologic causes of that kind of cognitive and memory change. We think about hardware changes, things like strokes or the beginnings of Alzheimer's disease, but often there are other factors, things like medication side effects, depression, anxiety, sleep disturbance, chronic pain. All of those can undermine memory and thinking, and that's where our clinic's expertise comes in addressing those and trying to peel away those layers that may be contributing to cognitive impairment and getting the person back to the mental and memory sharpness that they want to have.
Absolutely. Those are the patients that we can see a reverse of these symptoms, which, that's wonderful for those folks because they may think that something really difficult's going on. And with minor changes, some minor changes, things can be reversed. So let's get to where now through it, any of those diagnostic testings, you recognize this person definitely falls in the category for, mild neurocognitive impairment.
Okay. So we define mild cognitive impairment, or in the world of psychiatry, minor neurocognitive disorder, as a change in memory and thinking that's detectable on testing, that we can objectively measure, but isn't so severe that it interferes with everyday life. And so, as I've already pointed out, that gives us good opportunities for intervention, taking away things that might be making memory worse, and then adding, when we can, medications to help stimulate or improve memory performance, or potentially, if we find something like Alzheimer's disease as a contributor, now medications that can help to remove that pathology from the brain and hopefully stabilize the course. So that's sort of the first pass approach. We'll look at an MRI scan, looking for stroke or loss of brain cells, what we call atrophy. We'll look for nutritional factors, vitamin B12, vitamin D, and hormonal factors like thyroid. All of those can influence cognitive performance and are relatively easily treated.
Absolutely. Tell us about the infusions. What does that look like, and when is a patient appropriate for that treatment?
Sure. So we've had medicines for the symptoms of Alzheimer's disease and related disorders going back to the late 1990s. Those are medicines that folks will recognize as donepezil and memantine and related medications. Those stimulate the function of the living brain cells, help them work better, and hopefully stimulate memory performance and maintain independence, at least for a period of time. but they don't address the underlying pathology. They don't address the presence of the Alzheimer proteins in the brain that are causing the brain cells to not work well. So over the last couple of years now, several new medications have entered the marketplace that are administered by IV infusion and can pull out the Alzheimer pathology, the amyloid protein, which is one of the two key elements of Alzheimer's disease pathology. And by pulling that out of the brain, we can reduce the progression of the illness. The impact with today's medicines is still relatively small. We can reduce the progression of the illness by about a third, but that's still very important if you're the person with the memory loss.
Yeah.
And certainly we continue to work and hope for better medications, but for the first time, at least since 2021 or so, we're able now to treat not only to stimulate function with the old medicines, but to reduce progression with the new ones.
That's great.
The medicines there's one that's infused every 2 weeks, one that's infused once a month. And these we anticipate using for at least 6 months, and typically a year and a half would be our target period for therapy.
Okay, wonderful. So have you had, since y'all been doing this since 21, you have a number of patients now have gone through the 18-month regimen. What are you seeing for these patients that have been with you with these infusions for the last 3 years?
So that's a really difficult thing to measure. All of us, I think, recognize that Alzheimer's disease is a very individual disease, different symptoms in different people, different rates of change. So it's very hard to pick up in a one-on-one interaction. Has there been a slowing of the decline? And we know the first medicine that we began to use, the one called Aduhelm back in 2021, probably is not as effective as the two that have followed. And it now actually has been pulled from the market. So what we follow primarily is, are the memory scores staying relatively stable? And most importantly, at the end of the treatment period, does a PET scan show that there's been a reduction in the amyloid burden in the brain? And that's how we'll know the medicine is working, by the changes in either the blood tests, which aren't quite there yet, but will be, or the PET scans, rather than being able to track specifically a score on a memory screening test.
That's exciting.
Yeah. Quick question. At what point do you recommend or not recommend? Is there a too early or too late window or a sweet spot for infusions?
Sure. That information about is there a sweet spot is still growing rapidly. We're still learning a lot about that. So it's become clear from a couple of the studies that people in more advanced stages of the disease, what we might classify as moderate stage dementia from Alzheimer's disease, probably do not benefit from the medications. And it probably is along a continuum that the more mild the pathology is, the greater the relative benefit of the treatment. So trying to catch someone early, as we talked about before with mild cognitive impairment, becomes very important. If a person is already dependent on others for activities of daily living, meal preparation, filling the prescription, those sorts of things, they're probably too far along to show benefit from the medicine. The disease is already moving at a pace that the medicines can't influence. There are 2 studies underway right now, at least 2, that are looking at people who are even more mild than that, people who have the Alzheimer changes in their brain as detectable by PET scan or blood tests, but not yet detectable symptoms of memory loss. And so in 2027 and 2028, we expect to learn the results of those studies to find out if we can go even earlier. That is, find out that someone has Alzheimer changes in the brain based on screening tests like blood tests, and potentially treat that to prevent the emergence of symptoms. And I think that's where our future in this field will move over the course of the next decades, is toward true prevention rather than response to symptoms.
So will those tests be available for to primary care physicians? Clearly someone that is not recognizing any symptoms isn't coming to you at that time. So that would have to fall on them, correct?
That's right. And we'd have to see the results of the studies. And are the results strong enough to recommend for general use? And even more importantly, these are very complex medications to manage. And would a primary care doctor have the time and space available to oversee the treatment? And we simply don't know the answers to that yet. I think the infusion medicines that we have today and likely will be our core therapies for the next 5 years, probably will continue to reside in the hands of neurologists, just based on their complexity. In the longer term, what we learn from these studies and the use of the medicines in clinical practice may bring us to better, safer, easier to use medicines that hopefully then would generalize. Just like today, we treat heart disease in its nascent state. We begin treating heart disease when we find an elevated cholesterol and begin to treat that with medications. And I'm hoping that Alzheimer's disease moves the same way, that we'll have a blood test that will say, hey, your risk is high, take this medicine, and we can lower that risk.
That's so exciting. I mean, just to see the shift and the changes in all the research that you and your team and many others are doing for all of us is so exciting. So we've talked about this particular one, and it sounds like is it specific for the Alzheimer's type for dementia?
So I can elaborate on that. So Alzheimer's disease is characterized neuropathologically by two protein accumulations in the brain, one called amyloid, one called tau, in the form of neurofibrillary tangles. Under the microscope, that's what makes Alzheimer's disease. And the current infusion medicines target the amyloid and lower its levels in the brain. Other forms of dementia that might emerge from strokes or Parkinson's disease or frontotemporal lobar degeneration, don't accumulate amyloid and therefore aren't able to respond to this kind of medication. Research to come up with treatments for those kinds of illnesses continues and is being aggressively pursued. But right now, this depends on the Alzheimer's pathology as the cause of the cognitive decline.
And would you say that Alzheimer's is still the predominant diagnosis in the umbrella of dementia?
Yes, it is. It remains the most common cause of dementia out there for people over the age of 65. The older someone gets, the more they approach, their late 80s and 90s, the more likely they are to have more than one pathology. And so, again, our current medicines target only the Alzheimer components of that pathology. And we need to look at other preventative strategies like trying to prevent stroke and stroke-related changes to help keep those older adults well.
Right. What are you seeing? I mean, we're kind of diving into some of the other dementias. What are you seeing as far as research that, let's just tackle frontotemporal first. That definitely is one that it's not necessarily marked with what you see with like short-term memory and things like that, but it's going to be personality changes and some of the things that family members are like, oh my gosh, what is going on with my loved one? They're doing crazy things. Where are we there?
Yeah, so frontotemporal dementia is an extremely challenging illness. And it's challenging not only from the caregiver perspective, especially from the caregiver perspective because of the changes in behavior that predominate, but also biologically. There isn't one cause or one pathological change that's associated with the syndrome of frontotemporal dementia. So in Alzheimer's, we always know it's amyloid and tau. Mm-hmm. In frontotemporal dementia, there are other protein abnormalities and other genetic abnormalities that can influence the development of the illness. So the research continues. There is some very exciting research for people who have a particular mutation as the cause of their frontotemporal dementia, a mutation called the progranulin mutation. And there are now pharmaceutical companies that have developed techniques to help overcome that mutation. That's still very rare. It's a rare contributor to a rare disease, but it's the first sort of step that we have in being able to understand what's going on in FTD and replace the deficiency. So very important for that. In the world of Parkinson's and related dementia, people who get typical Parkinson's disease with the shaking tremor and the shuffling gait, if they live long enough, will often develop dementia. And so there are active research programs now looking at reducing the protein accumulation in Parkinson's and its cousin illness called Lewy body dementia. We've also improved diagnostics in those areas. So now it's possible to, with a greater degree of certainty, diagnose the presence of Parkinson's pathology in a person with something as simple as a skin biopsy. So really, really great progress in the diagnostics for some of those illnesses. Here in Alabama, stroke remains a major problem, particularly silent stroke, strokes that people don't know they're having. Those are complications of high blood pressure and diabetes and high cholesterol, and most importantly, genetic factors influence a lot of stroke. Um, to oversimplify, stroke punches holes in the brain, and our neuroscience is not at the point where we can bring back dead neurons. And so prevention is really the only approach we have for stroke and stroke-related changes. And I'm hoping to bring in an additional person onto our team over the next couple of years who can really focus on the stroke-related issues in cognition and how to optimize prevention or to minimize progression for those folks.
And wouldn't you say, I mean, when we talk about strokes, that's what we're talking about, vascular dementia is the kind of umbrella there. Wouldn't you say obviously the preventive things, but your cardiologist is going to be just as important in helping with the ongoing management and prevention of, further strokes and so forth than even some of the things that you guys are doing.
That's right. So in terms of vascular health, managing vascular health, proactively, preventatively, primary care and cardiology are key players in that. By the time you get to a neurologist with that sort of problem, you've missed much of the window for prevention. And really, we have a colleague in the overall Memory and Aging Hub whose focus is on brain health throughout life and optimizing cardiovascular health through lifestyle factors, diet, exercise, and those sorts of things. So we very much are partnered with folks looking at the prevention of vascular dementia as a key part of their work.
Absolutely. The medicines that you were mentioning, I mean, obviously we discussed the infusions and that they're Alzheimer's specific. And we see this, Nicole and I see this a lot across patients, where maybe they're using donepezil or amantadine and they fall and it's looking clear that they may have more vascular or Lewy body or things like that. Are those the right therapeutics for this person? I know we mentioned it's more kind of cardiovascular for the person that's more prone to strokes. Sometimes I feel like people out there in the community, and unless you kind of live in this world, you think, oh yeah, I have dementia, I need to take Aricept or whatever, but that's not always correct.
You're right. It's not always correct. And so the donepezil, Aricept, and its similar drugs, rivastigmine and galantamine, were developed specifically to address the chemical deficiencies that were understood in Alzheimer's disease. Now, those studies were done in the mid-90s, and a lot of practicing physicians were not around when those studies were being done. I was very fortunate to be a part of those studies and really coming to understand what they do and how they work. So they seem to have their best overall response in people with Alzheimer's pathology and their best overall response when that pathology is relatively mild. So mild dementia, maybe moving into moderate dementia. They were studied in stroke and stroke-related cognitive decline, so vascular dementia, and have some efficacy, but not as much as they do in Alzheimer's disease. And they've been studied in the Parkinson's-related conditions, including dementia with Lewy bodies, where they can have significant potency. The cholinesterase inhibitor drugs like donepezil can have very, very high potency in that population. So it's appropriate to use them in many situations. Frontotemporal dementia, not so much. And if the problems with cognition are due to some of the other things we've talked about, sleep apnea, chronic pain, depression, anxiety, then these medicines really don't target the things that would help those people be better.
Okay, sure.
So when go ahead. I was going to ask, a lot of times we see people that are in the more severe stages of dementia and they've never really received a diagnosis, but their primary physicians or their psychiatrists might be a little hesitant to take some of those medicines off of their drug list. Is there a reason why to advocate for not removing those or for keeping them in some way?
Understood. There is a trend in geriatric neurology and geriatric psychiatry, geriatric medicine as well, toward the concept of de-prescribing to reduce the use of medicines that may no longer be providing benefit. In the case of the dementia symptom drugs like donepezil, we have good data that says if the medicine is helping and we stop it temporarily, that is for a week or two, there would be a noticeable drop-off in the person's abilities, and we would restart the medicine, and those abilities would resume. They'd come back. However, if we stop the medicine and there is no discernible change in the memory or thinking or day-to-day behaviors, then that suggests the medicine has run its course and is no longer providing benefit. If we look at donepezil and rivastigmine and that class of medicines, the best suggestion is 3 to 5 years of effectiveness. Beyond 3 to 5 years, it probably wanes. It isn't there, and the medicine can be safely stopped in most people. For memantine, the data are even clearer that treatment periods of more than a year probably aren't providing ongoing benefit. And so the medicine can be safely stopped. But in each case, it's not a decision to say, hey, we're just going to quit. It is, we're going to take a holiday and see what happens. And if you get worse, or, as the family, if your loved one gets worse, that'll tell us the medicine was providing benefit and we'll go back on it. The key is how long are you off? And so the studies suggest that if you are off one of the medicines for more than a month, then you probably will lose whatever benefit had previously been there. And so that's why keeping this holiday to a fairly short period, holiday for observation to a fairly short period, is important.
That's good. Yeah. And I think what Nicole, especially when you're talking about when we're more in the moderate to severe stages, talk to us kind of what to expect for those patients. So, obviously that's where your team of more kind of behavior management, environmental management, caregiving support, and then when it's right and wrong to bring in medications helping with behaviors. So, kind of a disclaimer, Nicole and I are really, really strong on saying, let's look at the environment first. Let's take a step back. What led to that behavior? Is it something that we're doing or putting that patient in an experience that they're going to react because of, where they are in their brain and in their disease? So a lot of it we're causing, which means you don't use a medication. But then there are times with later stages when a medication is definitely needed and warranted.
Absolutely. So you've articulated one of our core practice elements at Brain Aging and Memory Clinic, and that is we never want to administer pharmacologic approach for behavior without also the non-pharmacologic approaches. And most difficult behaviors in people with dementia are triggered by something. They're triggered either by internal perceptions or by environmental factors. And so if we don't address the environment, the medicine never really has a chance. There are some exceptions to that, but and you've also described why nursing is the core of our practice, is this adaptation to illness, adaptation to environment is really one of the core principles in nursing, as is the family as the unit of care. Mm-hmm. So if I give a pill to someone, they have to swallow it, it has to work in their brain. But they're not necessarily the person most affected by the difficult behaviors. It's the family who bear the burden of those. So if we don't change the family environment, the same problem will continue to emerge. So you're right, managing environment is important. There are some medicines which can help reduce restlessness and agitation and may help promote mental sharpness that are very benign. And those include some of the modern antidepressant medicines like escitalopram and sertraline. And so we use those very commonly as part of our treatment approach. However, if it's things like agitation or aggression, that not only needs the environmental approach, but it probably also needs medicines to keep the person and their family members safe. Mm-hmm. And so we will move to some of our more potent and frankly more dangerous medicines if physical violence or verbal aggression or just feeling threatened is a part of the process.
Sure. And again, those need to be, obviously, I know y'all do this, very much emphasize the education to the family as when you use these, when is the right time? Is this something that needs to be on just a regular, like they get this daily, or is this something more as needed? We try to prevent as many of the as needed as we can because, most layperson, and even for those of us in the practice, it's hard to determine what was the trigger, those kinds of things, and when it's warranted and so forth.
Yeah, and it's always easier to prevent a difficult behavior than it is to react to it. So if you wait until a difficult behavior is building and you have a pill that's available, you take it, that pill's still going to take 30 or 45 minutes to really circulate and get into the brain and do the job it needs to do. So using a different medicine or a lower dose of the same kind of medicine proactively, as well as controlling the environment that might trigger the behaviors, is often more effective for everyone and safer.
Absolutely. Yes, there's not a magic pill to challenging behaviors. I think that's the key. And a lot of times families get to just their wit's end and they're looking for the quick fix. Mm-hmm. And a lot of times it's the quick fix of themselves, right? Yes. And it's the pill's not going to help your behavior. So we have to check ourselves first. And I know, go ahead, Nicole.
Well, we also tell family oftentimes too that a pill is not going to change someone's personality. So if it's their basic personality to be a certain way, be grumpy or be anxious, or there might be things to help that, but it's not going to change who they are at their core.
Yeah, that's right.
Repetitive questions are not fixed by a pill.
One of my colleagues used to say, in the course of dementia, people become more themselves every day. So those things that we may have been able to exert self-control over throughout our lives, whether it's our anger or our anxiety or our latent paranoia, whatever it might be, as cognition fails, those supervisory cognitive functions that inhibit those problems start to go away. So we find the anxious person getting more anxious and the apathetic person getting more apathetic and so forth. And that isn't true for everyone, but that's the general rule of thumb.
Well, we are uncensored. So one of the things that I think I want to dive in here is, kind of the forbidden conversations. And I think we're talking about that now, right? So for those of us right now, if I stump my toe right now, or if I, were to have a paper cut right now while I'm on Zoom with, this professional team, and we're trying to put this out in the world, my Rolodex is going to go through things and I may just try to bite my lip or just say, oh gosh, ouch, that hurts. If I'm by myself, I may say another 4-letter word, right? It still can be very taboo for families when someone has a diagnosis like dementia or, a mental health diagnosis, which are kind of hand in hand sometimes when we're dealing with dementia. And it's hard for families to kind of grasp and understand that mom never said these forbidden words. Now it's on the daily basis, or maybe with frontotemporal, we're saying really inappropriate, unfiltered comments or doing things that we seem to be, so forbidden in public or what have you. But how do we talk to families about that so that they understand that this is changes in the brain and not necessarily, it's not that person's fault?
Yeah, I think that I sort of addressed a little bit of that. I try to teach that we lose our control systems. The technical word in cognition is executive function. Executive function is that little voice in our head that says, now do this or don't do that. And as people move into dementia of all causes, executive function fails. It fails unpredictably. It fails intermittently. It depends on the strength of the stimulus. So that the person who had always been, as you mentioned, always been very reserved and, might have stubbed their toe and said, "Aw, shucks," might have a different response when their executive system isn't working. Or in the case of, you mentioned frontotemporal dementia, sexual disinhibitions are very common in that population. So the gentleman who always found the neighbor down the street an attractive person now begins to act on that attraction in a way that his supervisory systems would have prevented before. And in many ways, it doesn't mean that he is less bonded to his wife or his family. It's just that the ability to withhold the other attractions becomes limited. And so we try to talk about it this way. This is the illness. It's a direct consequence of the illness. We know how it happens, and we try to limit those factors that might trigger the behavior.
Right. It definitely takes, a whole team approach to care for the person that has the illness, and more importantly, care for the people that are caring for the person with the illness.
And And understanding is always the key. I think if people can put it into the context of this is the disease speaking, we wouldn't criticize an amputee for not being able to run a marathon, and we shouldn't criticize the person with a cognitive impairment or behavioral control impairment for changes in their cognition or their behavior. And that's a tough hurdle because it's easy to see an amputation.
Right.
It's really hard to see disinhibition.
And, with families, you're bringing just a history of skeletons in the closet, baggage and things like that, that something in their past, whether it was a traumatic situation or the way they interacted when they were younger, those things can really kind of manifest themselves when these family caregivers are working with their loved ones through this illness.
Absolutely.
I think that this brings us to a good point of asking about driving. And a lot of times family members want to ask the neurologist or the primary of saying, you have to tell my husband that he can't drive anymore. You have to tell mom. They're hesitant to do it. And we find that physicians are hesitant to do it. Can you tell us a little bit more about that?
Sure. Driving is one of the most difficult conversations that we have. It's also wrought with ethical issues embedded in it, the issues of autonomy and safety, personal health versus public health. And there are no simple answers in driving. What we know is a third-party observer is often our best choice for this. So when I do our memory testing in the clinic, and I see someone can't remember 3 words or might have difficulty drawing a clock, that's not watching them drive.
Right.
It's not observing the behavior in question. And there, as probably all of us on the call know, there are a lot of individual variabilities in what we consider normal for driving. And so when there are changes of this sort, it's difficult, if not impossible, for the healthcare provider to say, well, what you've told me means that this person isn't safe on the road. Because, I see lots of not safe drivers out there. Many of them aren't in a position where I would think they have a dementia syndrome. So there are some things that I ask families to look for. And if they tell me about these things, then I have a little bit more evidence. So not just mom's not safe on the road. Mom may have never been safe on the road. But things like I ask families to observe is the person driving at normal speeds for the circumstances and for their own habits. So they're going too fast or too slow. When following a car, are they following too close or too far? And same for stop signs. Are they too close or too far from the stopping line or the crosswalk? At intersections, are they judging the traffic appropriately? Are they following the right signals? Are they entering the correct lane? Are they exiting the correct lane to make a turn? Those kinds of objective pieces of evidence help me understand much more where the driving safety issues might be and how this is different. And that's always one of the important questions, is how it's different. So I hope she's not watching, but I use my wife as an example.
We hope she is.
And so when I'm talking to a family, I will say, and I try to make this very personal, I said, my wife thinks I drive like a little old lady. And so if I suddenly started to drive like her, she should start to be worried about my driving safety. And if she started to drive like me, I might be worried about her driving safety. So it's a change. Mm-hmm. The guidances are not very strong. So there are guidances to neurologists say, well, any dementia should not drive. And there are others that say 80% of people with mild to moderate dementia never have an accident. So we don't really have good data on it. So what I depend upon is a specialist. So here at UAB, we have the option to make a referral for our driving safety clinic. There's an occupational therapist who has a specific training and certification in driver safety. It's focused at rehabilitation. It's focused on people recovering after brain injuries or strokes and getting back to the road. But that kind of specialist can evaluate safety in all sorts of circumstances. So we'll make a referral to that occupational therapist and have their team do the testing, generate the objective evidence of how does the person do in a car, or objective evidence that they fail the tests in the clinic that predict driving or lack of driving safety. So that's the way we manage it, because they can see it. And for us, it's inference and hearsay for the most part.
Absolutely. So I think right now we'll kind of close up today's podcast, and then we'll be coming back really quickly, since we're going to continue this on, and dive into more of the fun things that are going on out in the world, and preventive things and research and so forth. So thank you so much, Dr. Geldmacher. This has been amazing today. I know that Nicole and I could sit here and talk to you all day long, but
We don't have all day long.
see you and the research needs you. So thank you so much. And thanks for tuning in. If you like our podcast, which I hope you do, like, subscribe, follow us on Spotify, YouTube, Apple. Am I missing anything, Nicole? I think that's all of us. So more to come, Aging Uncensored out there. And again, thank you so much, Dr. Geldmacher, for being our guest today. And we look forward to starting this next series in just a few minutes.